on renal physiology, you have been taught about the structure and the functions of the kidney. You all know that kidney is doing the function of excretion and other functions like concentration of the urine, maintenance of the fluid balance, maintenance of osmolarity of the plasma, and also acidification of the urine depending on the need. So maintaining of pH is another function that kidney is doing. So all these functions of the kidney you have already been taught. So now today's topic is renal function test. So when will you do the renal function test? So on any patient, sorry to move these slides. So the renal function test, when you will be performing. When a patient comes to you, there may be several symptoms. You cannot do renal function tests as soon as the patient arrives. You will have to take some history from the patient. You will have to do the clinical examination, and then you will be suggesting some of the renal function tests to be performed to judge the function of the kidney. Now, coming to the different renal function tests that can be measured. There are certain functions, as you know, the kidney, the nephrons are doing the filtration of the blood, and this filtration is how much filtration is, that is known by the glomerular filtration rate, and that is very, very important. So these nephrons are filtering the blood into plasma, the plasma which is flowing through the kidneys, and the filtrate is coming into the lumen space, and it is passing through the different areas of the nephron, different tubules of the nephron. And in the process of after the filtration, some of the solutes which are filtered, these are reabsorbed. Some of the solutes are also secreted. So ultimately, there is a formation of urine, through which the various unwanted substances are removed. So the renal function tests can be done on the basis like there is a measurement of the GFR, that is the glomerular filtration rate. There are tests for measurement of the renal function, renal tubular functions. So for measurement of GFR, there are clearance tests. These clearance tests are available. The plasma creatinine level is also can be used for the GFR functions. There is a normal level of plasma creatinine, and when this is raised, it can also be used as a marker of the measurement of glomerular filtration rate. Then urea and uric acid levels are also measured as a marker of the GFR. Renal tubular function tests. What are the different function tests? The specific gravity. The specific gravity of the urine is determined not only by the it is determined by the solutes like proteins and other solutes which are present in the kidney. The osmolarity measurements are also coming under this heading, because osmolarity changes are there as the fluid is passing through the tubule. A large amount of solutes are absorbed, and some amount of certain substances is secreted into the tubules. Then urine acidification tests can also be there. So as you know that kidney is handling the hydrogen ion also. Whenever there is an excess of hydrogen ion in the body, there will be more secretion of this hydrogen ion into the Then we are also doing the urine analysis. As a patient goes with some problem that he might observe in the urine, these patients are approaching to doctor, and doctor prescribe them to undergo certain tests, and urine analysis is one such test. So when we are doing urine analysis, we are doing the analysis of volume, how much volume of urine is there, because there is a normal volume that is normal volume of urine that is there, that is about 1 to 1.5 liters per day. Then appearance of this urine, whether is it the normal appearance, whether its appearance or the color has changed, so that again can be seen in the urine analysis. Again, specific gravity of the urine that is coming out, the pH of the urine, and osmolarity of the urine. Then various biochemical tests are also performed in the urine analysis, like presence of glucose. As you know that glucose is mostly reabsorbed from the urine into the blood. And if there is any presence of glucose in the urine, it is known as glycosuria. Presence of proteins is also normal. A minimal level of proteins can be seen as normal. But if protein is present in excess, then the normal value it is known as proteinuria. Similarly, in certain conditions, ketones might also come into the urine, particularly diabetes mellitus. So these ketone levels of the urine are also assessed. Other than this, there are urinary sediments. These urinary sediments may be like the crystals, there may be the blood cells or other cells, the pus cells, the casts, all these are coming into this urinary sediments. Then renal functioning can also be assessed through the various imaging tests. These tests can be ultrasonography, as it is done for other organs also. The CT scan or the computed tomography scan. MRI, that is the magnetic resonance imaging. Ultrasound guided renal biopsy. This is also another imaging test that can be done if we want to take some tissue of the kidney to assess its histology. So we can do this test also. Then there is another imaging test that is known as intravenous pyelography, which is also being performed in certain situations. Now, when should you assess the renal function? That is the question. So renal functions, you cannot say to every patient who is coming to you to get your renal function assessed. So there are certain population on which you can do the assessment of renal function. But these renal function tests per se are not the only thing that you will have to do in the patients, because prior to this you will have to see the patient, you have to take the proper history. According to the history, you will ask symptoms. According to the symptoms, you can again do the examination of the patient, and then you can just suggest them to undergo the various renal function tests. Like if a patient of diabetes mellitus comes to you, as you know, diabetes mellitus is a metabolic disorder. It is affecting the various organ structures in the body in the long term. So if you're taking the history, and in the history it comes out that the patient is diabetic, then you can suggest these patients renal function tests. Similarly, hypertension is a chronic problem. The patients who are having hypertension, there is a complication of this hypertension, and the various organ structures, including the kidney, can also be affected. So you can again assess the renal function in such patients. Then the patients with who are having a family history of chronic kidney diseases. Chronic renal failure or certain other disorders of the kidney. In those subjects, you can assess the renal function. Then decreased renal mass that you can assess from the ultrasonography or other techniques. There are certain autoimmune diseases which can affect the kidney functions. These autoimmune diseases, just like SLE or vasculitis. So SLE is a systemic lupus erythematosus. That is a condition, it's an autoimmune condition, and that can affect the multi-organ, including the kidney. Then systemic infections. When there is severe infection, these infections can again involve multi-organs. Kidney may also get involved in this. Then comes the urinary tract infections. What do you mean by urinary tract infections? These are the infections of the tract which is carrying urine from the kidneys to outside the body. So the entire tract is the urinary tract, and any infection of this tract is known as urinary tract infections. When these infections can ascend to the kidney, these may affect the kidney tissue as well. So that's why you should assess the kidney function test, the renal function test in such patients. Nephrolithiasis. What is the meaning of lithiasis? It is the formation of stones in the kidney. So these stones may get, these are made up of calcium crystals, calcium carbonate, and these may get deposited in the renal pelvis. Small concretions can be developed there. It might come into the ureter or the urinary bladder. So wherever it is obstructing the path of the urine flow, when it is obstructing the urine flow, it will affect the it will cause the back pressure, and this back pressure can affect the functioning of the kidney if this back pressure is not released, if the cause is not removed. Then obstruction of lower urinary tract. How there can be obstruction to the lower urinary tract? There may be, again, as I told you, stones, if they get deposited at a place where it is difficult to be removed, then again obstruction of this pathway is there. Then urethral strictures can be formed. Urethra, they get certain strictures, and these strictures will narrow the passage of the urethra, and this will lead to obstruction to the urinary tract. Then in older patients, there is a hypertrophy of the prostate. This hypertrophy of the prostate, as it is surrounding the urethra, so once there is a hypertrophy, large tissue will cause obstruction of the urinary pathway. This obstruction to the lower urinary tract will happen. There's a carcinoma of the prostatic gland can again cause this. Then there are certain drugs which are toxic to the kidneys, and if there are certain patients in whom these drugs might have to be given, we will have to assess these patients for the renal functions, so that if there is any derangement of the renal function, that drug can be stopped and further damage can be stopped. In old age patients, again depending on the symptoms, signs, and the presence of any other history of disorders, you can do the assessment of renal functions. Then what are the different tests for the renal function? So the first one is for the measurement of glomerular filtration rate, as glomerular filtration is one of the important functions of the kidney, and all the solutes which are passing through the glomerulus, these are being filtered. These filtrate which is coming into the tubule, that will ultimately form the urine. So GFR is very, very important for the normal functioning. Normal GFR is important, and the value of normal GFR, as we all know, is 125 ml per minute. So now there are certain clearance tests for measurement of GFR. Now what are these? So, in case of acute renal failure or chronic renal failure, there is effectively a loss of function of whole nephrons. As you know, that filtration is essential for the formation of urine. So, tests for glomerular function are almost always required in the investigation and management of patients with renal disorders. So, most frequently used tests are to assess either the GFR or integrity of the glomerular filtration variant. Now, as you all know, GFR has already been taught to you. I hope that briefly you must have been told how this GFR is calculated, what is the substance that can be used for measuring GFR. So by measuring urinary excretion of a substance that is completely filtered from the blood by the glomeruli, and it is not secreted, reabsorbed or metabolized by the renal. So what is clearance? Clearance is defined as the quantity of blood or plasma completely cleared of a substance per unit time. So to calculate its value, this is the formula for the GFR. So GFR is equal to. So here for measuring GFR, we can use a substance which is known as inulin. So this U-inulin means the urinary concentration of inulin. Inulin is a polysaccharide which is obtained from dahlia roots. That is a plant. It is a polymer of fructose. So when it is injected, it will be filtered by the nephrons and it will come into the urine. Now this inulin is having it is freely filtered substance. It is neither secreted nor reabsorbed in the tubules. So whatever amount of inulin is filtered, it will come into the urine. So we can measure the urinary concentration of inulin. So urinary concentration of inulin, which is multiplied with V, that is the urine flow rate, the rate of flow of urine per minute, right? So once we measure this, then we should know the plasma concentration of inulin. So this plasma concentration of inulin is also needed to calculate GFR. So by putting the urinary concentration of the inulin in this formula, as well as the flow rate and the plasma concentration of inulin, we can come to know the GFR. So clearance of inulin can be used for the measurement of GFR. Now, what should be the property of any substance that can be used for measurement of GFR? Why inulin is considered to be the ideal? It is because it is only filtered, neither secreted, not reabsorbed. The other properties of any substance that can be injected and calculating GFR it should not be metabolized. It should be non-toxic, and other thing that it should be freely filterable. It should not be reabsorbed. It should not be secreted. All these properties should be there in a substance which can be used for the measurement of clearance. Now, this inulin is a exogenous substance. We can also measure the clearance for the GFR, you can say, from the endogenous substance. Now, what this endogenous substance is the plasma creatinine. So, this creatinine is a substance which is released from the muscles. So 1 to 2% of the muscle creatinine spontaneously converts into creatinine. Muscle creatine is converted into creatinine, and it is released into the body fluid at a constant rate. So endogenous creatinine is proportional to the muscle mass. It is a function of total muscles. Creatinine released into the body fluid at a constant rate, and its plasma levels are maintained with a narrow limit. A small amount of creatinine is released, and its levels are maintained within a normal range of 0.6 to 1.2 milligram per cent. So, this is an endogenous substance, we can also measure its clearance by the same formula which we have used for the inulin measure. Now, will it be different or will it be same for the inulin? I mean to say whether the creatinine clearance as a measure of GFR, will it be same as that of the inulin clearance as a measure of GFR? Small quantity of creatinine is reabsorbed by the tissue, and it is also small quantity is also secreted by the renal tubules. So the value of creatinine clearance is not the same, but it is very close to the inulin clearance. There may be some variations may be there, but as it is an endogenous substance, its clearance can also be used for the measurement of GFR. But if you require very precise measurement of GFR, then inulin clearance is the best for the measurement of GFR. Now, why it is so, like, even if it is secreted by the tubule and it is absorbed by the tubule, then even when the value of GFR is quite close, how it happens? As you know that it is being reabsorbed and it is secreted also. So small amount of secretion will lead to more clearance of this substance. But when we are measuring the plasma level of creatinine, when we are measuring plasma level of creatinine, then if we see in this formula, here it is written as inulin and plasma inulin. Suppose if we change it with the creatinine, so urinary concentration of creatinine will increase because it is secreted more than the reabsorbed. So urinary concentration of creatinine will increase, but plasma concentration will also increase. As why it will increase? Because when we are measuring the plasma concentration of creatinine, certain other chromogens are also can be measured as creatinine. So actual value of creatinine in the plasma is less, but certain non-specific substances, chromogens are there. When we are measuring with some tests, this will also lead to false increased level of plasma creatinine. So these two factors, one that urinary increase and then the plasma increase of creatinine, will balance each other, and the value of GFR will be almost same as that of the inulin clearance, as we are achieving through the inulin clearance. Neither the blood urea nor the plasma creatinine increases much until the GFR falls below 30 ml per minute. So you can understand through this, like if you are only measuring the blood urea or the plasma creatinine levels, they might remain normal until the GFR falls below 30 ml per minute. So absolute GFR measurement can be done to assess the early damage to the kidneys. So once this GFR levels are increased, and then there will be a sharp decrease. GFR, if it has fallen below 30 ml per minute, below this level, there will be increase in the plasma creatinine. So at that level only, it will act as a accurate guide and sensitive guide for further changes in the renal function. So that's why we are not measuring only the plasma creatinine level or the blood urea level for the renal functions, as these may remain normal till the GFR is reduced to 30 ml per minute. So we can assess the GFR through the inulin clearance or the creatinine clearance tests. Then for measurement of GFR, the urea and uric acid, the blood levels of these are also considered as to be indicator of GFR. Although the levels of these will again increase when the GFR falls much below the normal levels. But still, these blood level of urea and uric acid are considered as a measurement of GFR. These are considered as marker of GFR. So if there is an increase in the blood urea concentration or uric acid concentration, then it is indicative of the glomerular functioning is decreased. So measurement of non-protein nitrogen containing compounds. Catabolism of proteins and nucleic acids result in formation of so-called non-protein nitrogenous compounds like urea as well as the uric acid. Plasma urea. Urea is a major nitrogen-containing metabolic product of protein catabolism in humans. Its elimination is a major route for nitrogen excretion. More than 90% of urea is excreted through the kidneys. It is freely filtered by the glomeruli. So whatever urea is coming into the glomeruli, it will be freely filtered. Plasma urea concentration is often used as an index of renal glomerular function. Although the plasma concentration will only reduce once the glomerular functions has decreased to very low values, the normal values. Urea production is increased, can be increased by high protein intake, and it is decreased in patients with a low protein intake and in patients with the liver disease. Because in patients with the liver diseases, there will be less formation of protein. So in that condition, the urea levels will reduce. So the normal serum levels of urea or plasma level of urea are varying from 5 to it should be 7 to 39. Is a mistake here. So you can take it as 7 to 39 milligram per deciliter. Although various books, different books are giving different values. Some says 15 to 40, some says 5 to 25. But there is a range for this, and this range is from 7 to 39 milligram percent. Now, the non-renal factors that can affect the urea levels. Mild dehydration. What will happen in mild dehydration? As there is a dehydration, so the water from the plasma, water in the plasma will be, or you can say the plasma will be less in the dehydration. So solute concentration, that of the urea concentration, will increase in dehydration. Then high protein diet, again, it will lead to more production of the urea, and the blood levels, plasma levels of the urea will go high. Increased protein catabolism. There are certain conditions, the metabolic disorders, when the protein catabolism is more. Those conditions, the muscle wasting, as in case of starvation, Again, muscle wasting in case of starvation will lead to the increased breakdown of proteins, and that will lead to increased blood urea levels. Reabsorption of blood proteins after GIT hemorrhages. Suppose there is certain hemorrhage at certain point in the GI system. And this blood which is reaching out, that will be digested and the proteins will be reabsorbed, that will increase the urea levels. The treatment of cortisol and certain other analogs. Again, as you know, the cortisol is having a protein catabolic effect. So the patients who are treated on these steroids, they will be having the higher blood urea levels. These steroids are required in various clinical situations like bronchial asthma or control the allergic conditions. In those patients, these steroids are being given regularly. So that may again cause the increased breakdown of the proteins and higher plasma urea concentration. Now, states which are associated with the elevated levels of urea in blood are referred to as uremia or azotemia. These states can be there in certain disorders. So now, what are the causes of increased renal plasma elevations? These causes can be divided into pre-renal cause, renal cause, or post-renal causes. Now, pre-renal cause means the cause is before, cause is not there in the kidneys, but the kidneys are having lesser perfusion. Decreased blood flow to the kidney is there in the pre-renal causes. Now, what can be the causes of the hypoperfusion? Different types of shocks, as we have already been told about, where the perfusion is less. If there is a cardiogenic shock, then again that will lead to decreased perfusion. If there is a septic shock, again it will lead to the decreased perfusion. So whatever may be the cause of that shock, that will lead to the decreased renal perfusion, and because of decreased blood flow, less amount of urea will be filtered and less will be coming out into the urine. So the levels of the urea will increase in the plasma. Then comes the renal causes, where the kidney per se is affected. The renal disorders, various types of renal disorders, and where acute tubular necrosis will be there, and the blood supply to the kidney is affected. And then this blood supply to the kidney is affected, there will be ischemia of the renal tissue, and then it can lead to the necrosis of the kidneys. That can be the cause, renal cause. The post-renal cause that can cause uremia or higher blood urea levels are the obstruction of the urinary flow. Now, how this obstruction to the urinary flow can occur? It can occur, as we have already discussed, like in case of nephrolithiasis, the stool is there, and if it is lying in the renal pelvis, it will obstruct the flow of the urine into the system, and this will create a pressure inside the kidney. This pressure will press upon the renal parenchyma. Once renal parenchyma is pressed by the increased pressure, there will be damage to the nephrons. So nephrons will be lost if this obstruction is not removed. So nephrolithiasis is one of the causes. Of the cause I have already just mentioned. There can be urethral stricture, or there can be the prostatic enlargement. All these can lead to the post-renal cause of the elevation of the urea in the plasma. Then uric acid. It's a major product of catabolism of the urine nucleosides like adenine and guanosine. So it is formed by the catabolism of these urine nucleosides, that is adenosine and guanosine. Overproduction of uric acid may result from increased synthesis of urine precursions. Now, hyperuricemia, it is defined by the serum or the plasma uric concentration higher than 7 mg/% in men or greater than 6 mg/% That is hyperuricemia. Now, till now we have discussed about the glomerular function. Now coming to the tubular functions. As you know, once the filtrate is formed through the glomerulus, it is coming into the tubules. So in the tubules, at various places, the various things are being reabsorbed. Water is reabsorbed, sodium, amino acids, glucose, proteins. If it is present in small quantities, some proteins are also reabsorbed. So specific gravity per se is affected by the presence of solutes. These solutes may be the presence of proteins or different other substances like glucose and other solutes. So if the protein concentration is higher in the urine, the specific gravity may be affected. So specific gravity may be taken as a tubular function. Then osmolality measurement. How much is the osmolality of the urine that is coming out? That is another tubular function. Then there's a test like urine acidification test. As you know that the hydrogen ion is secreted by the tubules into the urine. So how much is the capability, whether the normal function of hydrogen secretion is there or not, that can be taken up in the urine acidification test. So compared to the GFR as an assessment of glomerular function, there are no easily performed tests which measure tubular function in quantitative manner. So certain other methods that we devised for this investigation of tubular functions, like measurement of osmolality and specific gravity. So as you know, osmolality measurement in the plasma and urine. So normally urine to plasma osmolality ratio is between 1.5 to 3, 1.5 to 4. It means the normal urine can be 1.5 times having higher osmolality as compared to the plasma, and it can go the 4 times the osmolality of the plasma depending on the need of the body. In certain dehydration condition, when you are walking at 40 degrees Celsius and there is no water available to you, the kidney will tend to preserve water for you, and the concentration of the solutes in urine will be very high. So depending on the dehydration, of the level of dehydration, it can go to 4 times the osmolality of the plasma. Specific gravity of the urine normally is 1.010 to 1.030. So as I told you, it depends on the number of solutes. And if the large number of proteins are there in the urine, that specific gravity will be affected. So presence of protein in the urine is known as proteinuria. Normally, glomerular basal membrane does not allow the passage of albumin and large proteins. Small amount of albumin, which is generally less than the 20 milligram per 24 hours, is found in the urine. So this much is normal, less than 25 milligram in 24 hours. Urine protein excretion normally should be less than 150 milligram per day. In excess of 250 milligram per 24 hours, significant damage to the glomerular membrane can be seen. So quantitative urine protein measurement should always be made on complete 24-hour urine collection. Whenever you want to know the protein, how much is the magnitude of proteinuria, you should measure it in the 24-hour urine sample. You will ask the patient to collect the 24-hour urine. Then that collected urine is assessed for the protein concentration. So if the albumin is excreted in the range of 25 to 300 milligram per 24 hours. It is known as microalbuminuria, and it is suggestive of certain finding disorder of the glomerular of the kidney. So normally the pain should be in any case less than 150 milligram per 24 hours. In this diagram, you can see the flow. You can see here this arrow, this much amount of protein in a way is coming. It is being filtered here and it is being reabsorbed. This is happening in normal condition. So when there is a large amount of proteins in the blood, like in case of Vann-Jones proteinuria. Vann-Jones proteins are the proteins which are formed in case of patients with multiple myeloma. These proteins, these Vann-Jones proteins will increase the amount of proteins which are coming and which are filtered. So you can see this arrow has this was normal amount that was filtered. Now as the Vann-Jones protein concentration in plasma is increased, you can see large amount of proteins are coming into the tubule, and large amount of it is also reabsorbed, but you can see here the large amount is also coming into the urine. So even after the reabsorption, large amount of proteins are coming into the urine, and this is known as Vann-Jones proteinuria, and it is seen in case of multiple myeloma. So once this protein concentration is higher, so that is proteinuria, and it will affect the specific gravity of the urine. Here now you can see the amount of protein in the plasma is normal, but what is happening is at the level of glomerular membrane that is defective, and it is not able to keep the protein inside the vessel. Large amount of proteins are filtered because of some problem with the glomerular membrane. Permeability for the proteins has increased in the glomerular disease. So large amount of protein coming into the tubule, and it is large amount is reabsorbed, and large amount is passed into the. So this condition is albuminuria, and it is seen in glomerular disorders like nephrotic syndrome. There is a more permeability of albumin to this. So this albuminuria will be seen. Again, it will increase the specific gravity, and increase in the protein, increase in the. Then this problem in this condition where the beta 2 microglobulinuria is seen. In this condition, the normal amount is coming from the blood from the glomerular into the tubule, but the reabsorption of this is being affected to the tubule. Now, as whatever the normal amount of microglobulin is coming, it is not being reabsorbed, and it is filtered out. It will not be reabsorbed, and it will come out into the urine. So that is another form of proteinuria. The cause is different. Here, the tubular reabsorption is not taking place. Here, it was a glomerular defect. Here, it was the total amount of protein that was increased in the blood. Vann-Jones proteinuria. Now, here in this situation, this is a normal situation. The normal amount of whatever small amount is being filtered, it is being reabsorbed. But these there are certain proteins which are specific to the tubules, particularly the sending tubule and the collecting duct. These strong hotspot proteins are there which are released from the cells of the renal tubules. These proteins normally comes into the urine. These are known as Vann hotspot proteins. Now coming to the another test, that is the urine analysis. Any patient who is going to the doctor for any complaint in the urinary tract with the burning menstruation or something like that, then the urine analysis is being advised. So urine analysis basically advised not only to see whether the kidneys are being affected, but in certain other situations also you can do the urine analysis. So urine analysis is not only for the kidney functions, assessing the kidney functions. Like in case of diabetes mellitus, we are doing the urine analysis to see whether the glucose in the urine is higher or not. So urine analysis per se is telling about the several defects that can be there, along with the defect or the problem with the renal function. So when we are doing the urine analysis, what we are doing, we see for the normal, the volume of the urine is normal or not, the appearance of the urine, the specific gravity, osmolality, the pH, and certain biochemical tests like presence of glucose, protein, or the urinary sediments. Now, coming to the volume, normal volume is about 1 to 1.8 ml per day, or 1 to 1.8 liters per day is the normal urine volume. Now, conditions that can increase this urine output can be certain normal physiological conditions, like if you take large amount of water in a short duration of time, that will lead to water diuresis. So more water will be coming and the more urine volume will be there. But in situations like a patient is on diuretic therapy, which may sometimes be given to the hypertensive patient also. So this diuretic, as the name suggests, we are making the person to have diuresis. So more volume of urine will be there. Diabetes insipidus, and you all know that it is due to decreased release of ADH, or it can be the decreased action of ADH on kidneys, that is a nephrogenic diabetes insipidus. Then in diabetes mellitus also, there will be increased urine volume because of the osmotic diuresis. Now conditions that will decrease. So as in case of excessive sweating, if a person is doing exercise, the more sweating is there, so that amount of urine formation will be there. If the person is there in a higher temperature, higher surrounding temperature, again the sweating will be much higher. So it will tend to preserve the water as much as possible. So same is the case with dehydration. Dehydration may be due to diarrhea or may be due to the excessive vomiting. In that condition also, loss of fluid will lead to kidney to act and preserve as much water as possible. In acute renal failure, again, there can be a decrease in the urine output. So, there are different terms which are used with regards to the volume. These are one of the terms, the polyuria. The increase in the urine output is there, and when we'll say that it is polyuria when the urine volume is more than 2.5 liters per day. That is polyuria. Oliguria, urine output decreases. It ranges from 300 to 500 ml per day. And anuria, when there is a much decrease in the urine output, and it goes below 50 ml per day. So that is the condition when we say it is anuria. Now, when we are doing the urine analysis, so one was the gross appearance. Appearance is normally the straw colored urine is there, but in certain situations the urine color may change. Like in case of jaundice, color of the urine changes, and also in, it may be red in color when there is a hematuria. Now, coming to the microscopy, means you are just seeing what is there whatever urinary sediments are there, you can just see through the microscopy. So through microscopy, you will assess the cells, what type of cells are there, whether these are WBCs, RBCs, cells, or there are certain casts which are there, are there any bacteria or not, the crystals which are there. And the third part of the urine analysis is the biochemistry, that means you are just assessing the glucose levels and protein levels, glucose levels. You are assessing the pH osmolarity, creatinine, glucose, and urea level. Now, urine analysis can also be done with the help of disposable strips. These disposable strips are being dipped into the urine, and you will take out these strips and you will match the color. So depending, for different substances, we are using different strips, and there is a shaded color on the strips. So when you will dip it into the urine, depending on the color that is achieved, you can see about the concentration. Like a very famous that nowadays statistics are quite commonly used for the diabetic patients. These lipsticks can be used for the blood sample. Like blood sample is felt on these sticks, and one can assess the level of glucose in the blood as well. So these are used for the analysis. Different companies are producing these. So these are available for the glucose, for the bilirubin. So these are the color coding for all these things which are there. So you can just broadly see how much is the concentration. Here you can see for different colors, a different range of concentration of different compounds is being given here. You will match the color of lipsticks with these colors, and you can assess the concentration accordingly for a particular substance. Appearance, like I just told you, if there is a blood in this, red in color, the presence of blood in the urine is known as hematuria. There may be the presence of hemoglobin that can also give a different color to it. The presence of myoglobin can also give a different color to the urine. So if urine osmolality is about 600 milliosmoles per kg or more, the tubular function is usually regarded as intact. When the urine osmolality does not differ greatly from the plasma, means the ratio plasma to urine to plasma ratio is 1. The renal tubules are not reabsorbing water. So it is typically happens when in cases of the chronic renal failure, there is not much change in the difference in the plasma as well as the urine osmolality, as the reabsorbing capacity of the tubule is affected in those disorders. So when we do the urine analysis, we do analysis of the pH also. The normal pH range is 4.5 to 7.5. Urine is acidic in nature. The urine sediments, what are the sediments that can be seen? Microscopic examination of cells, cast, and complex. Presence of blood, that is the hematuria, may have its origin from the malignancy. It may be because of the urinary tract infection. And in females, when the sample of urine is taken, and if the menstruation is still on, the blood may come into the urine at that time. So we should rule out the cause of it. We just cannot say that if a blood is coming, in case of a female, the urine cannot label it as a abnormality unless we have ruled out the menstrual criteria. So red cell casts can be seen in glomerular diseases. Crystals, different crystals can be seen when you are doing the analysis, microscopy of the urine. Leukocytes. WBCs can be seen in case of acute inflammation in the presence of urinary tract infection. Urinary tract infection, they mean to say like there is an infection of the ureter or infection of the bladder or an infection with urethra. All these can lead to the presence of these cells, leukocytes, into the urine. Urinary casts. These are the cylindrical structures used by the kidney and present in the urine in certain disease states. They form in distal convoluted tissue and the collecting duct of the nephron, and they dislodge and pass into the urine where they can be detected by microscope. They form by a precipitation of TAM fast called mucoprotein. It has its origin from the tubules. And sometimes by albumin also. You can see the red cell casts in the urine. Then we see cell casts. You can see here. And the hyaline cast, the erythrocyte cast, leukocyte cast, and the granular cast. All can be seen in different conditions. So, time is next class is about to start. So I'll be stopping at this moment, and in my next lecture I will be covering the remaining part of this lecture as well as the artificial kidney dialysis. All those things will be covered. So I'm leaving now this webinar.